switch on your camera.
Sir, then it would be visible in the...
Okay. Leave it.
To understand the abdominal wall blocks or the interfacial plane blocks, we have to understand the related muscles, nerves, and the fascia. So I would start with the anatomy of the abdominal wall. The layers of the abdominal wall are skin, the subcutaneous tissue, the Camper's fascia, the Scarpa's fascia, superficial investing fascia. Then we go towards the external oblique muscle, and the fascia beneath it is the intermediate investing fascia. Then internal oblique muscle, the deep investing fascia, transversus abdominis, transversalis fascia, extraperitoneal fat, and the parietal peritoneum. All the flat muscles taper into the aponeurosis as they approach the midline, and they blend in the midline to form linea alba. The major three flat muscles of the anterolateral abdominal wall are external oblique, internal oblique, and the transversus abdominis. And there is one paired muscle in the midline, that is the rectus abdominis. Now in this video, we will see all the three muscles. This is the external oblique. If we remove it, we will see the internal oblique muscle. Beneath the internal oblique is the plane between the internal oblique and the transversus abdominis. With the serratus anterior and the lower slip interdigitate with the latissimus dorsi. The direction of these strips is downward, forwards, and medially, and it ends into a broad aponeurosis, as seen in the green in the right figure, which starts from xiphoid process to pubic symphysis, pubic crest, and the pectineal line. The distal end of the aponeurosis folds on itself to form the inguinal ligament, and the medial end of the aponeurosis contributes to the formation of rectus sheath. Iliac crest inferiorly and the thoracolumbar fascia posteriorly, and inserts on the inferior borders of the 10th to 12th ribs and the linea alba. Medial to the mid-clavicular line, internal oblique tapers off into its aponeurosis, and it splits to form the rectus sheath. Here on the image on the right, the green part highlighted is all the internal oblique aponeurosis. The transversus abdominis muscle originates on the internal aspect of the 7th to 12th costal cartilages, then the thoracolumbar fascia and the iliac crest. And it inserts on the linea alba and the pubic tubercle. It tapers off medially into the aponeurosis. It also contributes to the formation of the rectus sheath. The neurovascular structures of abdominal wall lie in between the internal oblique muscle and the transversus abdominis muscle. Now we come to rectus abdominis. It is a vertical paired muscle. It originates from the pubic crest and pubic symphysis, and it travels vertically upwards and inserts on the xiphoid process and 5 to 7 costal cartilages. It is encased within the rectus sheath. The rectus sheath is formed by blending of aponeurosis of external oblique, internal oblique, and the transversus abdominis. The superior 3/4 part of the rectus sheath above the arcuate line is anterior rectus sheath is formed by the external oblique aponeurosis and a part of internal oblique aponeurosis. And the posterior rectus sheath above the arcuate line is formed by part of internal oblique aponeurosis and the transversus abdominis aponeurosis. Whereas below the arcuate line, the anterior rectus sheath is formed by all three aponeuroses together, and the posterior rectus sheath is either absent, or we can say it is formed by epimysium and the transversalis fascia, as it is visible in this figure. Here we can see the anterior rectus sheath above the arcuate line, the posterior rectus sheath above the arcuate line, and below the arcuate line. There are 3 fibrous bands or tendinous insertions and inscriptions on the anterior rectus sheath on the anterior surface of the rectus abdominis muscle. This divides the rectus abdominis muscle into 6 to 8 bellies, whereas the posterior rectus sheath is unsegmented. Hence, above the posterior rectus sheath is the best part to deposit the local anesthetic. Now we come towards posterior abdominal wall. Of the three muscle layers of the anterolateral abdominal wall, the transversus abdominis and internal oblique taper off posteriorly into their origins, which are from the thoracolumbar fascia, as we saw before, whereas the external oblique, on the other hand, ends posteriorly in a free edge, and the QL muscle lies in the posterolateral abdominal wall. Now, the QL muscle originates from the posterior part of iliac crest and the iliolumbar ligament, and it inserts on the 12th rib and the transverse process of lumbar vertebra. So the thoracolumbar fascia is an important structure, which we will see further. It is a complex tubular structure of blended aponeurosis and the facial layers, which encases the deep muscles of the back. It splits into three layers: the anterior, middle, and the posterior layers. The posterior and the middle layer enclose the paraspinal, or mainly the erector spinae muscle, and the middle and the anterior layers enclose the QL muscle, as seen in this diagram. Here we can see the erector spinae muscle. There's posterior thoracolumbar fascia, middle thoracolumbar fascia. The QL muscle is encased by anterior and the middle thoracolumbar fascia. The middle thoracolumbar fascia is the target in posterior QL blocks, whereas the anterior thoracolumbar fascia is the target in anterior QL block. Here in this section, we can see the quadratus lumborum muscle, the psoas major muscle, and its proximity to kidney. Now we come to transversalis fascia. It is a thin areolar tissue that lines the deep surface of the transversus abdominis muscle, and separates it from the parietal fascia that lines the entire internal aspect of the abdominal wall. So it is continuous inferiorly with the fascia iliaca. It is continuous medially with the investing fascia of quadratus lumborum and psoas major muscle. It follows these muscles superiorly through the diaphragm, and it blends with the endothoracic fascia. This part is important for the potential spread of the injected when given in a block. Now we come to innervation of abdominal wall. The abdominal wall is innervated by thoraco-abdominal nerves, the ilioinguinal and iliohypogastric nerve. These nerves originate from the anterior rami of T6 to T12, and the T12 is rightly known as the subcostal nerve. These nerves each give off a lateral cutaneous branch in the mid-axillary line, then ascend to enter the subcutaneous tissue along the anterior axillary line, and it supplies the lateral abdominal wall. The anterior branches of the thoraco-abdominal nerves, they emerge from the costal margin and travel in the neurovascular tap plane. T6 enters just lateral to the linea alba. Then T6 to T9 enters in the tap plane medial to anterior axillary line. Then T10 to T12 enters the tap plane in transversus abdominis plane. The the lower segmental nerves, that is T9 to L1, give off multiple communicating branches, and they form a longitudinal tap plexus from which the terminal anterior branch. So the dermatomal image which we see or which we consider is not does not exactly correspond to its nerve, as there is a plexus and there can be multiple segments from which it may arise. The terminal anterior cutaneous branches enter the rectus sheath at its lateral margin. Here we can see all the lateral cutaneous nerves, and these are the anterior cutaneous nerves. Here we can also see the longitudinal tap plexus. Each thoraco-abdominal nerve after origin divides into ventral and posterior primary ramus. The posterior primary ramus travels through the paraspinal muscles, comes into the subcutaneous tissue, and gives off the posterior cutaneous nerve. This supplies the back. Then the ventral primary ramus continues into the transversus abdominis plane. At mid-axillary line, it gives lateral cutaneous nerve, and it continues and enters the posterior rectus sheath, then the rectus muscle, and gives the anterior cutaneous nerve. Same is seen in this diagram. The ilioinguinal and the iliohypogastric nerves. The L1 is divided in front of QL muscle into ilioinguinal and iliohypogastric nerves. Now the iliohypogastric nerve, it immediately enters the tap plane travels into the tap plane and then pierces the internal oblique in near the anterior superior iliac spine and becomes superficial near the superficial inguinal ligament after piercing the external oblique muscle. It supplies the skin over the suprapubic region. It also has a lateral cutaneous branch which supplies the upper and the lateral part of the gluteal region. The ilioinguinal nerve, it is again part of L1 in front of the QL muscle. It has no lateral cutaneous branch and it traverses the inguinal canal along with its content and emerges near the superficial inguinal ring. It supplies the skin of upper and medial aspect of the thigh and also the genitals. Now, what is the gold standard technique? Use of an epidural approach always remains the gold standard technique for analgesia after or during the abdominal surgery. This is because it covers both the somatic and the visceral components of the pain during the surgery. However, there may be contraindication to these neuraxial methods, and these may be, and patient is on antiplatelet or anticoagulant agents, patient has some coagulopathy, there might be hemodynamic instability or sepsis, and there might be a contraindication to epidural space access. Hence, we move towards the facial plane blocks. Now, what are the facial plane blocks? These are regional anesthesia techniques in which local anesthetic is injected in a plane or a space between two layers of the fascia rather than locating a specific nerve or a specific plexus. The mechanism of action of these facial plane blocks depend on the fate of the local anesthetic molecules in the facial planes. The movement of fluid or LA molecule depends on the mechanism of bulk flow or diffusion. The mechanism of bulk flow or mass flow is at macroscopic level, where the fluid moves as the body of aggregated particles is driven by pressure gradient, and the plane is distended by the hydraulic pressure of the fluid injection. Whereas in the process of diffusion, which happens at a microscopic level, there is a net movement of molecules within the fluid medium, and it is driven by concentration gradient. So fascia does not act as a barrier to diffusion, and it is freely permeable to local anesthetic. Thus, there are three possible fates of LA molecule when injected in a facial plane. First is that it spreads out and remains within the interstitial component of the plane. It bathes all the neurovascular structures which are present in the plane and causes anesthesia or analgesia. Then second is that it disperses out of the plane into adjacent tissue compartments by a mechanism of diffusion and bulk flow as explained earlier. And third is it can diffuse into the blood vessel and cause vascular absorption. This mechanism is beautifully given in this article by Ki Jin-Chin et al. Now, when it comes to facial blocks, there are multiple terminologies which might be overlapping and confusing. Therefore, this ASRA-Delphi consensus for study of abdominal wall to standardize nomenclature was given in 2021. And the final list said that the lateral and the mid-axillary tab block are commonly named as the mid-axillary tab block, and the lateral QL block and the posterior tab block are commonly known as the lateral QL block. It also gave the definition of all the blocks and the anatomical description, which we will see further. Now, how do we decide which block? So a successful block and a successful analgesia during the surgery, we have to decide which block is right for which surgery. For that, we have to ask some questions before planning for the block. First is visceral analgesia important? We have to remember that the facial plane blocks do not cover the visceral analgesia and they cover only the somatic component. And hence, we have to consider it as a part of multimodal analgesia, and we have to give either opioids or other analgesic techniques. Then second is, where is the incision for the surgery? Does the surgery require multiple incisions, single incision, and does our block cover all these incisions? Then we have to decide which block is feasible. The feasibility does not only depend on the surgery, but it depends on the patient position, whether we can change the patient position or we can lateralize the patient, the surgical field involved, If we are planning for a post-operative or a post-surgery block, are the wound dressings, the stoma side coming in our field? Then if we are putting any catheters, will the catheter come in the plane of dissection? So we have to decide. And even during after the surgery, if we are planning the block, we have to consider that there will be some disruption of the sonoanatomy. We also have to consider the desired analgesic duration. Now we'll come towards transversus abdominis plane block. It is a commonly used analgesic technique for surgeries involving the abdominal wall as a part of multimodal postoperative analgesia. As said before, it is limited to somatic component. It is highly dependent on the extent of the interfacial spread, and the myofascial spread of interest, as the name suggests, is in the transversus abdominis plane between the internal oblique and the transversus abdominis. The indications for TAB block are the upper abdominal surgeries, major exploratory laparotomies, laparoscopic surgeries like cholecystectomies, bariatric surgeries, major gynecological procedures, cesarean sections, renal transplants, nephrectomies, hernias, appendicectomies, and colorectal surgeries. First, we will see the classical TAB block or the loss of resistance TAB block. For the landmarks, first, it was described posteriorly in the Petit's triangle. We can see the Petit's triangle in the right image. It is formed anteriorly by the posterior border of the external oblique muscle and posteriorly by the anterior border of the latissimus dorsi muscle, and the base of the triangle is formed by the iliac crest. If we choose this landmark as our area of as our point of entry, then it will cover the dermatomes of T10 to T12 and possibly might cover ilioinguinal and iliohypogastric nerve. However, there is another approach which lies midway between the costal margin and the iliac crest at the level of mid-axillary line. And if we consider this area as our entry point, then only T10 to T12 dermatomes will be covered. For all these LOR blocks, we have to blunt the needle before giving the block. So there are multiple techniques for blunting of needle tip as shown in the figure. Either you can use a sterile bowl full of local anesthetic or distilled water and blunt a hypodermic by tapping into the bowl, or you can use a wider bore needle, use its bevel to parrot beak the needle. So we have to consider after blunting the needle, there's a concept called the cushion effect in the loss of resistance block. So what is the cushion effect? So when you insert a blunt tip needle in the skin, we'll first feel a resistance. Then to overcome this resistance, we will apply some pressure. After applying the pressure, the subcutaneous tissue gets compressed. And if we keep giving pressure, after a point, there would be a giveaway. This will cause piercing of fat, muscle, and sometimes it may also pierce the fascia. So if it pierces the fascia, we will miss the first facial pop, which is important during an LOR block. So to prevent this cushion effect, we can either withdraw the needle just after piercing the skin, or we can go needle through needle, or we can insert the needle parallel to the skin. First make the entry and then make it perpendicular and then start. Now in LOR TAB block, first after we insert the needle, we will feel the first resistance or the bounce of the external oblique fascia. Then it will, after piercing or popping that, we will feel the second resistance. And after popping the second resistance, that would be our area of interest between the internal oblique and the transversus abdominis. And we will deposit the local anesthetic in that region. Now we come towards ultrasound guided TAB blocks. The distribution of somatic analgesia with TAB block, it depends on the injection site and the volume of the local anesthetic use. There are four approaches: the subcostal approach, the lateral or the mid-axillary approach, the posterior approach, which is no longer now considered, and the ilioinguinal and iliohypogastric block or the anterior TAB block. The cutaneous sensory block covered in the subcostal, the dermatomes covered in the subcostal TAB are from T6 to T9 on the ipsilateral side. Then from lateral and the posterior TAB, we cover T9 to T12 on the ipsilateral side. And in anterior TAB, we cover T12 and L1. Now we come towards the subcostal TAB block. In subcostal TAB block, it is performed along the medial side of the costal margin in the upper quadrant of the anterior abdominal wall. For a landmark guided approach, we use 2 to 3 centimeter anterior to the anterior axillary line in subcostal region. Again, the concept remains the same as the LOR block described prior. We feel two resistances, that is two bounces, two pops, and after second pop, we aspirate and inject the drug. Now, for USG guided subcostal tap block, the patient is in supine position. The transducer we use is the high frequency linear array transducer. We keep the probe just below the costal margin, lateral to the xiphoid process. Then we start moving it more laterally as we scan. First, after putting the transducer just lateral to the xiphoid process, we see the rectus abdominis muscle and its posterior sheath just superficial to the transversus abdominis muscle. Then when we move it more laterally, we will see linea semilunaris, and we will appreciate after that the three muscles, the internal oblique, the external oblique, internal oblique, and the transversus abdominis. Here we use in-plane approach and we give the drug medial to lateral. In subcostal tap block, we have to consider that if we are giving the drug as an A point below the rectus abdominis and and above the transversus abdominis, the dermatomes of T6 to T8 would be covered. However, if we cross the linea semilunaris and we give the drug more laterally, then we will cover wider area, that is T9 to T10. Or we can start from A point and go towards the B point. This is the USG image of subcostal tap block. Here we can see first area of entry between the rectus abdominis and the transversus abdominis, and then we can move towards the internal oblique and the transversus abdominis plane. Now we come towards mid-axillary or lateral tap block. Patient lies in the supine position. The transducer we select is the high frequency linear transducer, and it is placed in the mid-axillary line between the costal margin and the iliac crest. After this is the probe position for the lateral approach, and we can see in the patient we have to use the needle in plane approach from anterior to posterior, and the end point of injection is between the facial plane in the internal oblique and the transversus abdominis. So this is the image, USG image. This is the external oblique, internal oblique. The area highlighted in the red is the tap plane, and then the transversus abdominis muscle, and then the peritoneal cavity. Usually the internal oblique is the most thickest and the fleshy muscle, and the transversus abdominis is the thinnest and the most hypoechoic muscle. This is the image showing the needle entry. The needle point is between the internal oblique and the transversus abdominis. Now this is a scan for tap block on right side. Here we can see the needle is already present in between internal oblique and transversus abdominis. This is the needle tip and the local anesthetic causing unzipping between internal oblique and transversus abdominis. Now we come to the posterior tap block. The patient position would be lateral or semilateral decubitus position. The transducer is placed in transverse orientation over the mid-axillary line between the subcostal margin and the iliac crest. Here we have to use the curvilinear probe. The abdominal muscles are identified in the mid-axillary line. All the three muscles are identified. Then we go more posteriorly till we find the internal oblique and the transversus abdominis insertion into the thoracolumbar fascia. And then the target is the most posterior end of the tap, lateral, just lateral to the QL muscle. So this is the probe position. We start from the mid-axillary line and we go more posteriorly. The needle is placed in plane in the mid-axillary line from anterior to posterior, and it is advanced through the abdominal muscle until it reaches the end of the tap. Here we can see the area of interest. Again, this is the QL muscle, the external oblique, internal oblique, and transversus abdominis, and its end. Now we go towards the ilioinguinal and iliohypogastric block, or the anterior tap block. The patient is positioned in supine position. We use high frequency linear array transducer. The transducer is placed in an oblique orientation with the lateral edge over the anterior superior iliac spine and the medial edge then pointing towards the umbilicus. along the spino-umbilical line. The needle is inserted in plane from medial to lateral, lateral to medial, and the tip is placed between internal oblique and transversus abdominis. So the A rectangle indicates the initial probe position. Then we rotate the probe and place it over the spino-umbilical line as indicated in the B position. The ultrasound image which we see is as given. So the internal oblique and the transversus abdominis and the plane between them. Sometimes we may see the ilioinguinal and the iliohypogastric nerve. Sometimes we may not be able to visualize, but the plane still remains the same. However, we have to keep caution and use color Doppler to identify the ascending branch of deep circumflex iliac artery and to help confirm the proper injection plane, and always aspirate before you give the drug. We use 15 to 20 ml of local anesthetic in this place. For ilioinguinal and iliohypogastric nerve block, for landmark guided approach, we first palpate the anterior superior iliac spine, go 5 centimeter cranially, then 5 centimeter posteriorly, and then after that, after the needle entry, the LOR tap remains the same. Now we move towards the transversalis fascia plane block. It was described to achieve the proximal blockade of the T12 and the L1 nerves, to achieve the analgesia of lateral subcostal abdominal region, the groin area, and the anterior part of iliac crest. So the indications where transversalis fascia plane block would be required would be like bone graft harvesting, appendicectomy, inguinal hernia repairs, etc. The patient is positioned supine. The transducer is in transverse orientation just above the iliac crest, and we trace all the 3 muscles and where it ends into the aponeurosis. In the left image, we can see the area where we give the transversalis facial plane block. In the right, we can see the ultrasound image where we can see just below the point of injection would be just below the transversus abdominis, where the transversalis fascia lies. In the right ultrasound image, we can see after the injection, there is a hypoechoic area created where we can appreciate it. The difference between the lateral QL and the transversalis fascia block is that in lateral QL, the injection is more towards the quadratus lumborum muscle. Now we come to the rectus sheath block. In rectus sheath block, the indications are like upper midline incision or paramedian incision, like umbilical hernia repair, incisional hernia repairs, and midline laparotomies. For landmark guided approach, we go 2 to 3 centimeter parallel to the midline, that is parasagittally, and the drug is deposited just above the posterior rectus sheath and below the rectus muscle. So after taking the entry, we will first feel the bounce of the anterior rectus sheath, then we will pop the muscle, then we will cross the rectus muscle, and we will feel a second resistance. Now, after the second resistance is felt, we will inject the drug and not pop through the second resistance. Here, 15 ml of LA would be deposited, and if we are giving bilateral blocks, then 15 each. The ultrasound guided rectus sheath block provides the somatic analgesia at the abdominal midline. We use the high frequency linear transducer. The patient is positioned supine, and the transducer is placed just superior to the umbilicus in a transverse orientation. Here we can see the transducer is placed just above the umbilicus, and we inject the needle in plane from lateral to medial side. After placing the transducer, we will first see the rectus abdominis muscle. We will appreciate the hyperechoic facial plane above the rectus abdominis, that is the anterior rectus sheath, and below the rectus abdominis, that is the posterior rectus sheath. Now in this video, we will see the scan of the rectus muscle in short axis. This is the linea alba. Then when we move laterally, we will see the anterior rectus sheath, rectus muscle, and the posterior rectus sheath. Just above the posterior rectus sheath, we have to deposit the muscle. If we go more laterally, we will be able to appreciate the linea semilunaris and the 3 muscles of the abdomen. Alternatively, we can also turn the transducer sagittally. It is rotated to 90 degree and positioned in midpoint between the xiphoid process and the umbilicus. This sagittal orientation results in longitudinal view of the rectus sheath, and we can see the tendinous insertion. So this is the muscle, tendinous insertion, and the anterior rectus sheath. We will appreciate another tendinous insertion here. This is a video showing the rectus sheath block. After we cross the muscle, just before the resistance is felt, we will inject the drug. So within the rectus sheath, bilateral superior epigastric arteries are present, and they anastomose with the deep inferior epigastric arteries. And these are at a risk of puncture during the rectus sheath block. So always aspirate before you inject. Now we come to quadratus lumborum block. The QL block is more consistent and extended block of the anterior rami of spinal nerve supplying the abdominal wall. It is located between the psoas major muscle anteriorly and the erector spinae muscle posteriorly, and its distribution depends on the site of injection. There are three QL blocks: lateral QL or the QL1, posterior QL, and the transmuscular or the anterior QL. So here we can see the dermatomal distribution of each block. The lateral QL or QL1 covers the area from T11 to L1, whereas the posterior and the transmuscular or anterior QL cover a wider range of dermatomes from T9 to L1. For the preparation of block, we use a low frequency curvilinear transducer. We require a 100 or 150 mm needle, 22 to 25 gauge. We use about 15 to 30 ml of local anesthetic. Always consider the weight of the patient before preparing the local anesthetic. Low concentration of LA are usually preferred, like 0.2% ropivacaine or 0.25% bupivacaine or levobupivacaine. The patient position would be lateral decubitus or sitting position. And for all the QL block techniques, the external landmarks and the scanning remains the same. The external landmarks are the iliac crest, costal margin, posterior and mid-axillary lines. Now we come to lateral QL. So the scanning for lateral QL is similar to that of the posterior tab block. That is, we place the transducer in transverse orientation at mid-axillary line between the costal margin and the iliac crest. Go appreciate all the three muscles of the abdomen. Go posteriorly to find their insertion, and along with the QL muscle, which would be appreciated as a triangular muscle, which would be the most hypoechoic muscle. The needle entry would be in plane, anterior to posterior or posterior to anterior. Here we can see the patient is positioned laterally. The probe is placed in the mid-axillary line and the needle entry in plane. We can appreciate the QL1 block in the image at the end of the transversus abdominis muscle, just lateral to the QL. So the name of the QL blocks are given according to the point of injection after considering the QL muscle boundaries. So QL1 block, here we can see as it is highlighted in yellow. In another ultrasound image, here we can see the quadratus lumborum muscle and the end of the transversus abdominis, this lateral point, we give the block. Now we come to the posterior quadratus lumborum block or the QL2 block. The scanning remains similar. The goal is to visualize the facial plane between the posterior aspect of the QL muscle and the middle layer of thoracolumbar fascia. The needle entry, the needle is inserted in plane, usually from posterior to anterior end of the transducer, and the aim is to go to the posterior aspect of the QL. So here we can see in the right image, we can see the QL muscle, its posterior boundary. So the drug would be deposited between the QL and the erector spinae muscle. And on the left side, we can see the ultrasound image, and the point of our entry would be, point of injection would be highlighted in green. Now we come to the anterior or transmuscular or QL3 block. The transducer, the scanning remains the same. we have to place the transducer in transverse orientation over the patient's flank, just cranial to the iliac crest, and then tilt it a little bit caudally here. Here we have to visualize the acoustic shadow of the L4 transverse process and its vertebral body. Then there would be the erector spinae muscle posteriorly, QL muscle laterally, and psoas major muscle anteriorly. This would form a leaf-like sign, that is the shamrock sign. The needle entry would be in plane from posterior to anterior, and here the needle passes through the two muscles, that is the erector spinae and QL muscle, hence known as the transmuscular QL block, until it reaches the plane between QL and psoas major muscle. After confirmation of the correct needle tip position, then the block is completed with the injection of 15 to 20 ml LA while observing the spread. So here in the left image, we can see the plane between QL and psoas major muscle is considered in transmuscular QL. And in the ultrasonographic image, we can see the needle shaft and the needle tip, the tip between the QL and psoas major muscle. Now, this is a video of scout scan before the QL block. Here we'll identify all the muscles and which we have described prior. This is the external oblique, internal oblique, and transversus. We slide posteriorly. Here we can see the vertebral body, tip, QL, and the shamrock sign. And then the needle insertion, the needle tip points for each block. There is another approach for anterior quadratus lumborum block, that is the subcostal approach. This is the parasagittal oblique approach, where the transducer is placed parasagittally and a little oblique, and the needle trajectory would be from caudal to cranial. So here we would be able to visualize all the three muscles in longitudinal views, and this is an easier approach for anterior QL. So most superficial in the second image, that is the H image, we will be able to see the most superficial is the erector spinae muscle, then the second is the QL muscle, and the third is the psoas major muscle. And we can see the hyperechoic facial plane between the QL and the psoas major muscle, which would be our plane of interest, and we would inject our local anesthetic here. Also, there are other variations of QL block like transverse oblique paramedian QL. It is similar but performed at level of L2, where ideally we perform at the level of L4, or suprailiac anterior QL block perform at the level of L5. Always use color Doppler during the scout scanning before inserting the needle, as there would be lumbar arteries on the posterior aspect of QL muscle. We should also identify the lower pole of kidney during the scout scanning, so as we don't go deep and damage and cause visceral injury. Now we come to external oblique intercostal block. Now for area, now to cover the area above the umbilicus, some blocks have been described like the subcostal block and the external oblique intercostal block. The problem with subcostal block is that it targets only the anterior cutaneous branches but spares the lateral cutaneous branches. Whereas in external oblique intercostal facial plane block, the lateral abdominal coverage above the umbilicus is gained. So here we can see in subcostal, the yellow part is only covered, that is the midline and parallel to the midline. The lateral part is missed, that is supplied by the lateral cutaneous branches. Whereas in external oblique intercostal, we cover the lateral abdominal area as well. These can be used in open cholecystectomies, hepatobiliary surgeries with chevron incisions, nephrectomies, liver transplants, etc. So a good chunk of external oblique muscle lies above the thoracic cage, and the rectus muscle also attaches to the rib cage on the 5th to 7th ribs. So the idea is needle is advanced from above and local anesthetic is deposited just deep to the external oblique muscle at 6th to 7th rib. It will then spread to anesthetize both the lateral and the anterior cutaneous branches of the intercostal nerve from T6 to T10. So in this image, we can see the star mark is our point of injection. So the local anesthetic will spread both posteriorly and anteriorly. After spreading posteriorly, it will block the lateral cutaneous branch, and after spreading anteriorly, it will block the anterior cutaneous branch. Here also we can see the point of entry is between the costal cartilage and the external oblique muscle. The probe position would be parasagittal oblique position, and the needle entry would be in plane from cranial to caudal direction. This is an image to show our point of interest between the intercostal muscles and the external oblique muscle. So this is a scout scan for external oblique intercostal facial plane block. Here we can see the costal cartilages and the intercostal muscles in between. So this is the rib, the intercostal muscles, and above is the external oblique muscle, and this is the facial plane of interest where the LA is deposited. The complications of facial plane blocks are needle trauma. There can be inadvertent vascular puncture. There can be intraperitoneal puncture or intraperitoneal injection. There can be a visceral injury, like in QL block, we can go towards the kidney. So that is possible. If we have missed the plane, there would be maldistribution of LA. Sometimes in transversalis facial plane blocks or QL blocks, if we inject larger volumes, the local anesthetic may also travel towards the lumbar plexus, and sometimes it may block femoral nerve as well and causing quadriceps weakness. Then there would be local anesthetic systemic toxicity. Post-op, even if we have given the block, the patient may still complain of visceral pain, and hence its lack of utility, and there might be LA myotoxicity. So my takeaway points are, these are high volume blocks. Always calculate the drug dose and drug concentration before giving the block according to patient's weight. These blocks are not for surgical anesthesia, part of multimodal analgesia in perioperative period. Always be aware of the vasculature in the plane and choose the appropriate block for successful analgesia. These are my references. Thank you for patient listening.
Thank you, Harsha. So we are open for discussion now. Gaurav, I think Ritesh was there.
Sachin sir
Sachin.
also, sir.
Yeah.
So, Harsha, you said these are high volume blocks. So, what concentrations and volumes generally you limit to?
So if we are considering bilateral blocks, like for example, bilateral tap or bilateral rectus sheath blocks, we consider 0.2% of ropivacaine, 0.1 to 0.2% of ropivacaine, or if we are using bupivacaine, 0.25% of bupivacaine would be used, and volume would be 15 to 20 ml.
Okay. So in QL, I think you can go up to almost 25 to 30 ml, right? If you want a good coverage.
Yes, sir. Right, sir.
Okay. Then one more common question that is asked is that there are no nerves in the lift area. So what
Yes,
is the
sir.
mechanism of action of QL2?
Okay, sir. So in QL2, so the lift area is bound by the middle thoracolumbar fascia.
Okay.
So and the erector spinae muscle. So that is a lacunar area where the middle thoracolumbar fascia splits.
Okay. So the given explanation, anybody else wants to answer? So the proposed mechanism is there is a dense network of mechanoceptors and nociceptors there, which contribute significantly to the analgesia due to QL. The second mechanism is the flow of the drug towards the anterior portion of the QL.
Okay, sir.
So what for a say umbilical or ventral hernia mesh repair when they use tackers, what
Yes, sir.
kind of block would you give? What would be sufficient for you?
We can use bilateral rectus sheath block for that region, or for the tackers are usually very painful in post-operative period. So first, like choice would be, some surgeons prefer epidural analgesia as well for post-operative period, and if we are considering blocks, then I will prefer bilateral rectus sheath block.
Sergi, any points?
Is it enough rectus sheath block, or will you like to add something?
Sir, it's not enough because the tackers cover a larger aspect.
So which block will you add?
Mid-axillary tap block.
Okay. So how much will be the volume for each block and concentration of the drug?
So if I am considering bilateral tap and bilateral rectus sheath block, I will give 0.2%, approximately 0.2% of ropivacaine, 20 ml in tap block, and 15 ml each in rectus sheath block.
Okay. Gaurav, Senthil, Pooja, Sangamitra.
Hello.
Yeah.
Harsha, it's a good presentation.
Thank you, sir.
Nicely depicted. And is there any other major complication other than the vascular injury when you give a QL3 block?
Sorry, sir, I am unaware.
What are the structures nearby?
So there would be psoas major, so it can cause inadvertent lumbar plexus block.
Yeah. So if you're not careful with your needle puncture and needle trajectory, if you're not able to see your tip of the needle, then you are more prone to injure the lumbar plexus.
Lumbar plexus, yes.
And they say that you will have to deposit the drug if the plane between psoas major muscle and quadratus lumborum muscle, suppose it's 10 centimeter in the plane is 10 centimeter. So
Yes.
you deposit the drug in the middle of the plane. If you put the drug towards the spinous process of L4, then it might seep to lumbar plexus also.
Okay.
If you're going beyond the middle of the facial plane, then you are more prone to injure the kidney.
Okay.
Even though you have a buffer of the perinephric fat, sometimes what happens if you're giving post-operative block when the kidney is removed, the facial planes are altered, then you might still will not be able to this thing. If the patient is in GA, you can stop the ventilation and you can give, but it is preferred to give your drug in between the middle of the plane of the between the psoas major and quadratus lumborum.
Okay. Yes, sir. Yes.
Is there any other approach for anterior? Why anterior quadratus lumborum block is more important than other blocks? Like suppose if you want to give one single block bilaterally to a patient for any intra-abdominal surgery, then I think you might have to choose QL3, which is anterior quadratus lumborum block, which covers totally from T6 to T6 to L1. You can cover both, and it has both visceral and somatic analgesia.
Yes, sir.
So in that case, suppose if you are not able to give position to the patient surgery is in supine, unlike your nephrectomy patients. Suppose you want to give the patient without changing the position for some other reason, you are not able to change the position. Can you approach the anterior quadratus lumborum supine?
With the subcostal approach, we can with the subcostal or like paramedian oblique approach, we can.
That paramedian approach was like the patient in lateral position or supine position,
We
as
have
you mentioned.
described it in lateral position. It was described in lateral position.
Okay.
But
There is an approach described by our Sandeep Diwan sir.
Okay.
The supine coronal mid-axillary approach to anterior quadratus lumborum block. I have tried in 2-3 patients. I had an analgesia up to like 6 hours.
Okay.
Because the patient had an external fixator in the pelvis and urinary bladder injury. So I couldn't give a patient
Lateral.
position.
Yes.
So I had done that block based on Sandeep Diwan sir's
Okay.
description.
Okay, sir.
This is also one more approach that for anterior quadratus lumborum.
Yes.
That's what I wanted to say.
Yes, sir.
Here the issue is that if your patient is supine and you want to your probe can only go up to the posterior axillary, and if you put a
Right.
wedge,
Hmm.
so you need to put a wedge to access the anterior QL via in the supine position, but your needle will always come from medial to lateral. So it is in more danger of causing injury to the abdominal organs. Right? If you keep the patient lateral, then you can come from medial to lateral. So that becomes a transmuscular approach. So
Yes,
if you
sir.
want to avoid that, you need to make the patient lateral. If
Yes.
that is not feasible, giving a wedge gives you an area of injecting. So one more question I wanted to ask is, in a fat patient, you have so many multiple layers of fat you'll be able to see. Is there any way of knowing that these are the three muscles and it's not any fat layer?
So the easiest way to know, first thing would be that the internal oblique is the most thickest and the fleshiest muscle. Other thing is, if we slide the probe, we can see as the external oblique and internal oblique travel in the opposite direction, we will be able to see the movement in the opposite direction. If still not confirmed, we can start counting from skin, then we can go to subcutaneous tissue. Then if more hyperechoic layers are visible, then we can count the campus and the scarpa's fascia as well, and then keep counting. Or we can start from down below, that is, if we can see the bowel movement or the peristalsis, then we can start counting from downwards to superficial layer.
Fine.
Any questions from fellows?
Just I want to correct one thing only. Harsha, good evening, Hetal sir. Good evening,
Good
Sachin
evening.
sir.
Yeah.
Good evening, all. Harsha, if you to know the directions, the external oblique and internal oblique runs in the opposite directions. The striations, but sliding, rather than using a sliding word, we can use a tilting back and forth.
Yes.
If you tilt the probe back and forth, you will come to know that the striations run in the opposite directions.
Yes. Yes.
Yeah. And one more question I want to ask is for rectus shape block, what is the end point? So what is the ideal needle tip position for the rectus shape block?
Just above the posterior rectus sheath.
Yeah, you are correct, but in a more correct way, it is between the epimysium of the rectus abdominis muscle and the posterior rectus. As it looks like a thick complex like posterior rectus shape, then the transversalis fascia and the peritoneum.
Yes.
So millimeter by millimeter, if you insert the needle, you will hydrodissect, you will come to know all these layers. So the
Yes.
correct plane is epimysium and the posterior rectus shape.
Yes.
Harsha,
Gaurav, from
what is
from your side?
Harsha,
So just one comment that we are using QL 1, 2, 3 nomenclatures. Now the nomenclatures, standard nomenclatures for exam purpose for all fellows, this should be anterior, lateral, and posterior. No 1, 2, 3. That is the only thing, sir, I wanted to
Yeah.
tell the fellows.
Yeah, that's true. We should use the nomenclature described recently in the RAPM. So it is for abdominal wall blocks as well as for the chest wall blocks. So we should use that only. We should forget now QL 1, 2, 3. That's true, Gaurav. Anything else?
So also, Also, it is better to have a test injection of 5 cc NS to start with, because facial planes sometimes can be very difficult to unzipper. So you should not waste the LA in the intramuscular plane. So it's better sometimes to start with around 5 cc of NS and see that you're in the right plane, and then probably change the syringe to the actual LA if you have got the good facial plane.
One
Yes,
more
agreed.
thing, Harsha, what is the main difference between any plexus block and the interfacial plane block? I mean, regarding the onset of analgesia, what precautionary explanation you will give to the surgeon or to the patient?
Sorry, ma'am, you are not audible.
Yeah, I'm
Uh,
repeating my
Your
question.
voice is breaking. Yeah.
In comparison to plexus block, what is the significance of interfacial plane block regarding the onset of action?
so it would be a delayed onset. The facial plane blocks will have a delayed onset as compared to the plexus blocks.
Yes, so most of the time we give the block at the end of the surgery and extubate. And at that time, multimodal analgesia should be started, because being a interfacial plane block, it will take its own time, unlike brachial plexus or lumbar plexus block. So you have to counsel your surgeon and patient both that this is not the failure of block or delayed block. It is the normal time taken by the block to act.
Yes.
Sangamitra, I have a different opinion. Like we should give block always immediately after GA rather than giving it at the end, because two advantage. First is what you explained, like onset of the block is delayed. So by the time during surgery, onset will be there. So intraoperative analgesia will be there, and reduced requirement of general anesthetic drug. And the second advantage is if we give after surgery, sometimes facial layers are distorted. So sometimes it is difficult to identify the facial layer, and it is difficult to give block. So it is always better to give the block before putting the incision. That is
Agreed, sir.
what I believe.
Agreed. But most of the time, the surgeons are so much in hurry after GA that whatever we want to give, we have to wait for him to complete the surgery. So yes, it will be ideal to give the
Yeah.
interfacial plane block at the end of GA only.
What is, sir, can I ask one?
Yeah, please go ahead.
So Dr. Sangamitra had asked regarding the onset between the plexus limb blocks and the facial plane blocks. So what with respect to the postoperative analgesia VAS score, how it is?
So, sir, if we are not giving any other analgesic, the patient might still feel pain due to visceral handling. And the analgesia would be somatic analgesia lasting up to only 8 to 10 hours at max if we are using a single shot block. And if we are using a catheter technique, then we can prolong, but it is very tedious.
No, I will reframe the question. Suppose you are giving an interfacial plane block and the patient is having VAS score of 5.
Okay.
So do you think the interfacial plane block that you have given is acted?
Yes, sir. Like the
This
incidental
I have
pain.
learned it from Dr. Hetal sir and Amit sir in a CME. They have told facial plane blocks. If the VAS score from 10 it comes to 5, which means that it has acted. It is not like limb blocks where you get 100% like VAS 0, VAS 1, VAS 2. So from VAS 10 to VAS 5, VAS 4 also, it means that your block has acted, but it has a delayed onset. You'll have to wait that much time.
Yes.
And mostly this is not, the facial plane blocks are usually not for surgical anesthesia,
Yes.
only for analgesia purposes. If at all, there will be case reports where patient has given facial plane blocks for anesthesia also. Perhaps they would have used an higher dose and an infusion perhaps. But then usually interfacial plane blocks are analgesic blocks, not for anesthesia.
Yes, sir.
Any other questions? Otherwise, we can move to quiz.
So
Sangamika?
there are a few questions, I think, in the chat.
Yeah.
Reshma Nath is our fellow. Does anterior QL help in IT femur fracture? If so, how? And how does tab block help in C-section or laparotomy, since it covers only somatic analgesia?
Harsha.
Okay. Harsha, you want to answer this?
So in C-section or laparotomy, as we said, it solely doesn't cover completely, but there is some relief of the incision and the facial and the muscular layer which are being dissected. But we have to give other analgesics as well. So somatic analgesia as described before. And
Correct. And QL for IT femur.
no, sir, we are not aiming to give lumbar plexus block here. So we will.
No. The question is, does QL help in IT femur fracture? If so, how?
It would just like cause relaxation of the paraspinal muscles. That's it. It won't help in much.
No, there are some reports, Harsha.
Okay.
Yeah. So there are some studies which show that QL helps in IT femur fracture analgesia. The proposed mechanism of action is seepage of the drug towards the neuraxial side.
Okay.
That is the only proposed mechanism in this. If anything else, I think Hetal sir would be able to answer that. I
No.
remember that much only.
If you pierce the psoas fascia, then it's more becomes a lumbar plexus block. That is probably the reason. So it is an inadvertent, probably this thing.
Inadvertent
But
lumbar plexus block or a
yes,
psoas block?
inadvertent lumbar plexus block. So I don't think so. Anyways, QL will be planned for an IT femur as a first choice. So nobody would probably want to give QL if there are other choices, especially if the patient is supine. Unless it is a primary block, then you would have to intend to puncture the psoas fascia so that you inject it into the psoas muscle.
I've read some case report like giving QL block for hip surgery, especially when patient is on anticoagulant. There are, I think, few case reports.
Yeah.
They use primarily for, of course, it is a side effect, but they use it for analgesia.
But again, it will be a controversy, sir, because patient on anticoagulants giving QL also is a not a right choice.
Right.
The point is, do you have any other good block to give for this patient? You have a lot of blocks, so you would not want target QL as the primary block for an IT. But it can help as an inadvertent this thing.
That's true.
Yeah. Just my one point is that when you already have so many superficial blocks for an IT femur, why do you want to go for a QL?
Exactly. Exactly.
Right, sir.
And just to add for the tab block, I think Reshma is also our fellow. She's asking, Reshma, are you there?
Yes, sir. My connection had gone. So yes, sir, I'm back.
So just to add your question, Harsha has already answered. Just to add that whenever you are answering such kind of question, no, you for any surgery, you have three things to look for. One is somatic, one is visceral, and if it is a bony this thing, then osteotome also. So somatic, visceral, and osteotome if it is a bony thing. So here your abdominal blocks will cover the somatic analgesia. For visceral, you need multimodal analgesia. So your answer will cover these headings, and accordingly you will answer.
Okay, sir.
Thank you.
Anything else?
Sir, that QL mechanism.
For C-section rather than tab block, so we can go for a lateral QL block, which covers L1, which is the phalansteal injection.
For tab block, you can go like anterior QL, that is ilioinguinal iliohypogastric nerve block in tab plane. So you have to go just above the iliac crest and deposit the drug in tab plane, and that will also cover both ilioinguinal iliohypogastric, and it provide good analgesia for LSCS patient. Of course, lateral QL is also good. Pooja, you were telling something.
Sir, Reshma asked that question about the QL block and the IT fracture. So, in somewhere in the literature, it is given that posterior QL also acts like it goes to the lateral tap and fascia transversalis, and then it might go to the fascia iliaca plane as well. So, in that way, also it adds. It's not the primary block, but just I have read it somewhere in the literature. There is systematic review which mentions about the drug spread till the fascia iliaca plane when we give the posterior quadratus
Yeah, yeah.
compound.
I also read somewhere. So
Even I read that.
when you inject the drug in facial planes, it may go anywhere.
Hmm.
So such things happen, and it provides analgesia in any surgery. Gaurav, you were telling something.
Yeah, the same thing, sir. Repeating the same thing that you were telling, that it'll sip into the area where it is finding least resistance and it'll block.
Yes,
So in IT fracture, there is another nerve which is called the cluneal nerve. So
yes,
cluneal
sir.
nerve supplies also some part of that area. That is why when you give a posterior incision, the cluneal nerve block is important, which can be covered with a fascia transversalis block or a paraspinal
Uh,
the S1 area. Okay, so that is where you can block the cluneal nerve. So the mechanism of action of QL is that the facial drug sips into the various areas. It could be fascia transversalis, it could be the paraneurachal area, and hence block these nerves. But again, said for exam purpose for fellows, you can refer these references and frame your answer. But obviously, when you are choosing for exam purpose, for answering in your exams, in your vivas, in your theory, you should mention that we already have so many superficial blocks. Why go for a QL block, which you will need the patient to be lateral position? Obviously, tedious things to do, right?
Plus the needle depth, sir. The
Sorry, ma'am.
needle travel path compared to a superficial block.
Yeah.
Why to take that pain?
Yeah.
Any more questions and doubts from fellows?
Sir, one question I want to ask to Harsha. What is the mechanism of interfacial plane blocks?
So the exact mechanism is not described, but as I mentioned, there would be like 2 to 3 um, parts of it, where either it can, as the drug reaches the interfacial plane by then it would bathe the nerves which are present and cause the and cause the analgesic effect. The other thing would be either diffusion, or there would be a bulk flow to the areas
Yes,
which are already open. So there would be a mass flow due to the pressure which is created while giving large volume of drug. And third thing, which is the vascular absorption, which
yes,
happens in extremely less quantities. So yes.
yes.
So now we can move to quiz, Sangamitra.
Yes, sir. Is it visible?
Yes, go ahead.
Yeah, please scan and join the link.
बोल रहे हैं।
Anyone else joining? Shall I start, sir? So Dr. Kapil is leading. Subcostal tab blocks which set of nerves? Again, Dr. Kapil is leading. Which of the statement is wrong concerning tab block? Correct. I think Harsha has made my quiz very easy. We were talking about the triangle of Petit. Bit of confusion here. It's a high volume, low concentration block. She's, I think, Dr. Harsha. I don't know. Fine. It's wider area. Again, Dr. Kapil is on top. Confusing one. Okay. It is quite confusing. This was very well explained by Dr. Harsha. Perfect. ICM is intercostal nerve block. Transverse process. Hash is leading. Simple one. Ooh. If you got it correct. Correct. This one is difficult one. Hamilton. Rafi talked about diabetes. This is an easier one. Most of you got it correct. Last question. Correct answer is QL muscle.
Congratulations, all of you. Please introduce yourselves.
Sir, Hash is Dr. Harsha.
Hello, sir. Good evening. This is Dr. Naveen, sir, from Sancheti Hospital.
Congratulations, Naveen.
Thank you, sir.
Hello, sir. I'm Dr. Tejas from Rubiol Clinic.
Congratulations, Tejas. And congratulations to all of you. Any concluding remark, Sangamita?
Very well presented by Dr. Harsha. She has very well covered the topics and cleared most of our doubts. And it was very well done, Harsha. But this time the fellows were very quiet, sir. Rest of the fellows.
Yeah.
It
I
was a
don't know why.
one-woman show this time.
Thank you, ma'am.
Yeah, Harsha. Next time we hope more participation from the fellows. So let's see.
So request to Harsha to share all the articles which you use to prepare the presentation in the cluster group so that everybody will be benefited. And if possible, if you have prepared any notes, you can share it. Thank you, everybody.
Yes, sir. Thank you, sir.
Good night.
Good night, sir.
Thank you, sir. Good night, sir.